coming to get down. I'm coming to dance.
Hello, everyone, and welcome to this week's edition of Chat Night Africa. This is Chat Night Africa live from Washington, D.C. metropolitan area. On Chat Night Africa this week, we will have a special guest connecting from California. He is a world standard oncologist, Dr. Sunny Bukhari. This is Chat Night Africa. Chat Night Africa transmission director, Mumbalingwa. This is Chat Night Africa live from Washington, D.C. metropolitan area. Production supervisor, Dr. B. Tatsong Famundam. Social media platforms manager and video editor, Sir Roger Fool in Lagos. This is Chat Night Africa studio manager, Beatrice Fomunen. Chat Night Africa from Washington, D.C. metropolitan area. Production collaborators, Eno Daniel, John Tantor, Lord Benson, Manuel Wayindi. Chat Night Africa Live, compiled and presented by Divine Chamukan. This is Chat Night, the power of Chat Night. Ladies and gentlemen, as I said earlier on, this is the guest who will be live on the show from California, Dr. Sunny. Dr. Sunny on the screen now. Dr. Sunny Bukhari on the screen. That's our guest, the world-renowned oncologist connecting from Fresno, California, United States. Thank you, Dr. Sunny, for coming on Chat Night Africa Live. This is Chat Night Africa from Washington, D.C. metropolitan area. On Chat Night, we weaponize you. We give you information because information is power. This is Chat Night, the power of Chat Night Africa. Ladies and gentlemen, before we get into the nooks and crannies of the topic, our correspondent, special correspondent, Jerry Johnny is on the line from Nigeria with This Week in the News. Hello, Johnny.
Hello. Thank you so much for joining us on Chat Night Africa Live. We're back from Nigeria, where the State Police Command has declared a lawyer wanted for
We are having that live report from Nigeria. We're having connectivity issues. We cannot take Johnny this evening. Maybe Johnny will have to do the report recorded. This was a first attempt to get Jerry Johnny live from Akwa Ibom State in Nigeria. Ladies and gentlemen, here is my guest this evening. My guest is Dr. Sunny Bukhari. Join me in welcoming him. Dr. Sunny Bukhari, thank you for joining us on Chat Night Africa this week. We are grateful that you accepted our invitation. You are a very busy person, yet you find time to be on the show. We are very, very grateful. Do you ever sit and think about what life would look like if one morning you find that you can't get out of bed because of illness? We tend to take so much for granted. And one of those things we take for granted is health. You don't know what you have until you don't have it. Ladies and gentlemen, as you watch this broadcast, many are in bed, very, very sick. Some sick of cancer. And today we are on colon cancer. Doctor, once again, welcome to Chat Night Africa Live.
Thank you.
My first question to you, Dr. Sunny Bukhari. Who is Dr. Sunny Bukhari? Who are you?
Well, in brief, I'm a Ghanaian. I did my medical school in Ghana. I graduated in 2005 in University of Ghana, after which I practiced for 2 years in Ghana. I did my housemanship and started pediatric residency before I transferred to the United States, specifically Wayne State University in Detroit, Michigan, where I pursued internal medicine and pediatrics and graduated 2012. So as we speak, I'm board certified internal medicine physician as well as board certified pediatrician. I then worked for about 2 years and then did my oncology training in the same institution in Detroit, Michigan, graduating in 2017. Between 2016 and 2017, I was the chief fellow of hematology and oncology program in Wayne State University. And then I joined University of San Francisco Fresno program in 2017, and I currently work in Community Cancer Institute, which is an affiliate of University of San Francisco in Fresno here. My main focus as far as cancer care is leukemia and lymphoma, even though I see some colon cancer.
Dr. Bukhari, why should anyone sit around and watch a broadcast on colon cancer? Typically, people hear of lung cancer, brain cancer, breast cancer, prostate cancer, pancreatic cancer, and a few others. Tell this person watching you, why should they sit around and listen to you?
So, ironically, colon cancer has been an important cancer years ago, and it's still very relevant. The reason why it's not as commonly talked about is the fact that it usually happens in older people. So in the past, we've always associated colon cancer with older people. But you will be surprised to know that colon cancer is actually second to prostate cancer in terms of incidence as well as cause of mortality. So when you take, for instance, in the United States alone, it is estimated that in 2020, about 148,000 people will be diagnosed with colon cancer at various stages. It is responsible for 8% of cancer deaths in the United States. This is how grave the situation is. And in the past, we always thought colon cancer, as I said, is a disease of the older people. But increasingly, we've noted that the incidence is rising in younger people, especially young Black men, even though the incidence is also rising in women, but it's much more common compared to Black women. It's much more common in Black men. It has been brought to the limelight most recently due to the event that happened with the death of the artist in the US, Chadwick Boseman of Black Panther fame. And so a lot more people are hearing about it, but as the providers or cancer specialists or the individuals who provide cancer care, we've always been talking about it, and we are trying to increase awareness about it. So to give you perspective, compared and especially when you look at racial distribution, overall, when you take 100,000 people in the US, the incidence is about 38 per every 100,000 people. That is the whole population. But when you divide it into race, The incidence is about 20 to 25 per 100,000 for Caucasians or white, compared to 51 in 100,000 in black. So twice as common in black men compared to Caucasian. And then 1.5 times as common in black women compared to Caucasian. So it's one of the few cancers that we are beginning to emphasize more, especially for individuals who are black or of African ancestry.
We are talking about colon cancer. Where in the body does cancer, where does that cancer, colon cancer, attack? Where? I want to.
So it would have been
I'll
nice.
make sure that my questions are as basic as they can be, because we have a cross section of people across the world, especially Africa, watching this broadcast. Colon cancer, where exactly in the body does it attack?
So this is the cancer that affects the part of the human body called colon. When you take what we call the digestive system, it starts from the mouth through the food pipe into the stomach, not the stomach as in what you see physically, but stomach as in what is inside you. And then the stomach then continues into a small intestine, which is about 6 feet long. And then the small intestine empties into a large intestine, which starts on the right lower side, goes up on the right, and makes a turn under the liver to the left, and makes another turn down to where we call anus, and then ends or rectum, and then ends into an anal canal, through which you pass stool. So it's a cancer that affects that part of the intestine called large intestine, which starts from the end of the small intestine to the end of anal canal.
And I have that diagram on the screen so that everybody can
So
watch.
if you can see the screen, the right side of the screen, that is where the small intestine enters the large intestine, and then the large intestine then moves from the right, goes all the way up to where the what we call the right upper quadrant of the abdomen, which is where the liver is located, and then it makes a transverse progression from the right to the left, and then now it goes down to the left, makes another turn into the anal canal where you pass through to. So let's say when you eat food, the food first starts in your mouth, goes through the food pipe into the stomach, it leaves the stomach into small intestine, it makes its way from the small intestine to the large intestine, and then it becomes stool, and then you pass it through the rectum. So any cancer that starts from the end of the small intestine through the anal canal or rectum to the anal canal. So because of that, even though we say colon cancer, but we lump colon cancer and rectal cancer in the same category. So in oncology, we call it colorectal cancer. And that is completely separate from the anal cancer, which is the cancer around the anus.
Thank you, doctor. Now, what exposes, because I want to imagine that that's the question that a lot of people are asking this evening or as they watch this show. What exposes the human body to colon cancer attack? Is it what human beings do or don't do?
So, what we call risk factors varies from something that you are born with, which is called congenital. And then the congenital risk factors can be divided into something that your parent passed on to you, which is the genetic component. and then something that the baby acquired during the development. And so congenital risk factor, and then we move to risk factors associated with life as you start from child till the day you die. So if you divide it into that, some of the genetic risk factors are inherited. So for those who want to know a little bit more, there is what we call hereditary polyposis syndrome, where some people inherit genetic makeup that puts them at risk of developing what we call polyps. Polyps are small projections or outpouch into the inner side of the large intestine that develop with time. And some people inherit genetic makeup that puts them at risk of developing polyps. And these polyps, some of them may outgrow itself and become cancerous, while some may remain non-cancerous. And then there is another hereditary syndrome called Lynch syndrome, where individuals develop a group of genes or a group of genetic makeup that put them at risk for developing colon cancer, even without developing polyps. So just to separate these two conditions, there are some people who develop colon cancer from developing multiple polyps, and there are some people who do not develop polyps, but out of nowhere, the inner lining of the large intestine becomes cancerous, which means that the cells there, out of nowhere, decides to grow unchecked. And then there are people who inherit certain group of genes or genetic makeup called breast ovarian syndrome, where they may have family members who have breast cancer. Some of them have ovarian cancer or cancer of the ovary, who also have tendency to develop colon cancer. So that takes care of the genetic component of it. What about the non-genetic component? Diet is one of the biggest risk factors for developing colon cancer. For instance, westernization of our diet, where instead of taking high starch, high fiber diet, we take a lot of refined sugar, or diet which doesn't have enough fiber or starch in it. For instance, biscuits and some of our processed food, they process it and take out the fiber component of it. I must say that most people, especially the first generation Africans who moved to the United States, still maintain African diet, which is relatively richer in fiber compared to the Western diet. But as the generation move on from first to second to third generation, people tend to adopt a more westernized diet, which is much less, which contain much less fiber. Other risk factors that have been noted include obesity or bigger body habitus, diabetes, tobacco use, alcohol use, eating of a lot of red meat. And then there are some conditions that also put people at risk of colon cancer. They include what we call inflammatory bowel disease. And there are two components that are important. There's a Crohn's disease and there's ulcerative colitis. So individuals with those two conditions are at higher risk. And then I have to also mention some protective factors. They include regular exercise, taking of food which is rich in high fiber. For instance, if you take cassava-based or corn-based or vegetable-based diet, will have a lot of raw veggies and fiber. And then people who take folic acid, vitamin B6, calcium, and vitamin D, and most recently, we also noted that in the use of aspirin, whether it's in non-steroidal anti-inflammatory, of which aspirin is part, also are somewhat protective.
You are watching Chat Night Africa, and the topic this week is colon cancer. My guest today is Dr. Sunny Bukhari. Now you can pick up your phone and dial the number 240-603-7367, 240-603-7367. As we see on the screen, if you are overseas, you can do WhatsApp call. You first dial 001-240-603-7367, and you will be asking Dr. Sunny Bukhari your question about colon cancer. Well, I dare say if you have a phone today, you have a specialist oncologist. I tell you, these guys are expensive to consult. You're lucky that Chat Night Africa can bring together these guys so that you can bring them on the platform so you can put your question to them. So again, pick up your phone and dial the number. If you have a phone tonight, you have a doctor. Dr. Sunny Bukhari, you've indicated or enumerated all the risk factors. How do I know that I have a polyps that has developed into a colon, or it become cancerous? How do you know that you have it? Walk me through stages 1 to 4.
So, just before we get there, I need to just mention few what we call signs and symptoms. Overall, a big majority of the people who have early stage, what we call stage 1 colon cancer, do not know, because they are usually diagnosed during a procedure we call colonoscopy, which is used as a screening tool. But unfortunately, for most people of Africa or African ancestry, and those who live in communities where access to healthcare is limited, they don't either follow through with their screening colonoscopies, or they develop certain signs and symptoms which signify early stage disease but do not really seek attention until it becomes late. Some of the early stage signs and symptoms include what we call change in bowel habits. So change in bowel habits can be what is changed from what is normal to you. For instance, if somebody uses number 2 or goes to toilet maybe once every 2 days or once a day, and then all of a sudden there is a change from once a day to once a week, in the appropriate age group, that signifies a problem that needs to be checked soon. Or somebody who who never had that loose stool, and all of a sudden they have diarrhea interspaced with constipation, or change in the caliber of stool. For instance, if the stool becomes very thin and pencil shaped, or short pellet of stool, is also an indication that all is not well. Other signs and symptoms include belly pain, belly distension, weight loss, changes in appetite, bloody stool, and bloody urine. Bloody stool is an important, bloody stool or dark stool. So if you have dark stool in somebody who is not taking iron therapy, especially if it is dark and loose, that's also a sign that you are probably bleeding somewhere. And our first worry is either in the stomach, not as in abdominal wall. So I'm going to refer to stomach and abdominal wall. Abdominal wall is what you see on the surface. The stomach is what is inside, where the food first goes to before it goes to the intestine, or bleeding in the intestine. Also, if you see blood in your stool, especially in the right age group, we don't want to assume that this is hemorrhoid because you don't know for sure. Yes, hemorrhoid is the most common cause of bloody stool, but colon cancer is the most deadly cause of bloody stool. So, I mean, those are signs and symptoms. But as I said, majority of patients or people with colon cancer are diagnosed during what we call either screening colonoscopy, where they get checked because they are at the appropriate age group. And that age group generally is age 50, even though nowadays, because of increased incidence of colon cancer in younger Black men in particular, we are pushing more towards age 45 as a screening, initiation of screening tool. Initiation of screening. And the other thing is the age of initiation is also very much dependent on your doctor's classification of your risk. So each person needs to check with their primary doctor and get risk classification, because there are some patients who are low risk, there are others who are high risk. And so when you take your family and personal history into account, for normal people without any additional risk, the screening age is probably 50 years. But if you have risk factors, let's say your direct family member, father, mother, or direct cousins have colon cancer at age 45, your screening has to start at least 10 years earlier than the age at which they develop theirs. And that is where a lot of people get it messed up.
Very important, yeah.
Or
very
if
important.
you have high-risk condition.
Very important
or if
information
you have,
that you give, sir. When you mentioned eating meat, that got my attention, because we love meat. Let's face it.
Yes.
In lots of African countries, they call it suya. Where you go, you have this grilled meat. It's just oil just dripping. Sometimes they put peanut on it. It's just mouth-watering. In the United States, they call barbecue, and we are soon getting into a season.
Yeah.
We're already there, that when people eat a lot of steak, you put it on the fire and people are singing, drinking wine and just feasting on meat. How much meat is too much meat that exposes you to colon cancer?
Yeah, good question. When we say red meat, we mean significant quantity. There are some people, they take it almost every day. We are not referring to somebody who takes it on, let's say, Christmas, Easter, few occasions here and there. No. There are some people, meat has to be on the table every day. That kind of intake is what I'm referring to. So maybe I should qualify it by saying excessive red meat intake. And then, there are other additives to the meat. We call it like the added salt and speckles and all that, which, we always say it's a risk factor. So we don't know for sure how much exactly. What we know is that people who take a lot of it are more likely to develop colon cancer.
Still talking about red meat. Sometimes, and in many villages across Africa, you see this meat is drained. Either it's put on top of the rooftop, or it's put over the fire. And in the United States, lots of Africans tend to put it in the oven to drain the blood or whatever liquid out of it. Would it make a difference? What is it in red meat, according to the studies that you've done? What is it in red meat that would predispose somebody to colon cancer?
So, to be honest, we don't know exactly what's in there. Red meat, if you probably will get a Nobel Prize if you're able to identify the exact chemical. What we know is the association. And when we say association, we mean when you take people who take a lot of red meat compared to people who do not take a lot of, let's say, when you take communities that are purely vegetarian, or who take minimal meat, the incidence of colon cancer is much lower in those communities compared to communities where meat and red meat is a staple. I don't know if that answers your.
Yes, I'm getting reports. I'm getting signals from Nigeria that our correspondent for African Affairs, Jerry Johnny, will be on the show. He is on the line with his report, first report. Thank you, Jerry Johnny, for staying up this night to file your report live from Nigeria on Chat Night Africa. This will be a weekly menu. We appreciate you. Now, Dr. Bukhari, when you say a lot of Black people tend to develop colon cancer, is it something in us, in our genes, that take us, or things that take us down that path to developing colon cancer, or what is, or it's just the color of the skin?
Yeah, so I think it's a combination of
watching
factors.
You would be saying, why we Black people, why Black women, why Black men?
Yes,
when the same blood runs, when the same blood runs through the veins of both white Caucasians, Chinese, Indians, and Africans.
Yes, so there's some genetic components to it, and because the incidence in Black happen at much younger age, that is a signal to us that there may be some genetic component to it. And that is why it is important to have a regular or primary doctor or family doctor who takes your family history and evaluate your risk. Like I said, the recommendation of doing screening colonoscopy at 50 years is not one cap fit all. We have to tailor the recommendation to an individual. So let's say if I have Mr. Kofi, whose father had colon cancer at age 42, okay, and who comes to see me, if it is possible, if the father had genetic testing of their colon cancer to determine if they have a Lynch syndrome or hereditary polyposis colorectal cancer gene, we can check Mr. Kofi to see if he also carries that gene. If we don't know, because of the fact that his father had colon cancer at age 43, we can easily nowadays, especially in the United States, we can easily send a blood test to evaluate him for hereditary colon cancer gene. If he has that gene, then the recommendation changes completely. So even if he's 30, we know that as soon as he gets to 33, which is 10 years younger than his father, we need to start the screening test. Because what makes a difference in the survival of the colon cancer is when you get diagnosed. Let's say if you are diagnosed with early stage disease, and I'll talk about the stages in a few minutes. You get diagnosed as early stage disease, your survival rate, your ability to get cured or to live past 5 years after your diagnosis is about 90% or 9 out of 10. So if you take 10 people who get diagnosed early, 9 of them will be alive at 5 years, compared to 10 people who get diagnosed late. Only about 2 or 3 of them will be alive 5 years. So, the way so because of that, we believe that there may be some genetic component to the Black family or Black people. And then there is also an acquired component of it. The acquired component is changed from indigenous diet, indigenous African diet, which is usually high fiber, high complex carbohydrate diet, eba, omutuo, those kind of food have relatively high fiber, moving to westernized diet, where it is refined sugar, pastries, biscuits, really refined sugar compared to complex,
At what point, tell me this.
And then,
yes. At what point?
And then last but not the least,
yeah, go ahead. Go
we
ahead.
also believe there's some component, especially in the US, there is some element of health disparity. And when we say health disparity and accessibility of health, for instance, let's say if you take somebody living in, say, California, if you live in LA County, where there are a lot of doctors, and you are also insured, you are likely going to seek healthcare much earlier compared to if you live in, say, few other counties where there are very few doctors and then most people are not insured, that kind of thing. So it's multiple factors. And so, one of the things that we always want is to get people enlightened, educated, so that, they will seek healthcare, as soon as anything changes.
Dr. Sunny, you said that earlier on that one of the symptoms of colon cancer is blood in the stool. Are you talking about a lot of blood in the stool or just a little blood in the stool? That's the first question. Second question is, when you talk about screening, do you have to wait until you see a little blood, so much blood in your stool, or it just becomes a routine thing? If it's a routine thing, at what point age do you, and what's the frequency of the screening?
Okay, good question. So, we don't want to wait till the point where you see blood in the stool. When you see blood in the stool, there's a good chance that you already have advanced colon cancer. Okay, so the blood in the stool comes in so many forms. It can come as real blood, where you see red blood in your stool, usually mixed with the stool. Usually not at the end of the stool, like on the tissue paper, but it's generally mixed with the stool. Or you can see a dark stool, which also it signifies old blood. Okay, so that's also not good. And then occasionally there are some people who may not even know because they have what is called microscopic blood in the stool, where this can only be determined through testing. So any form of blood in stool needs to be evaluated, especially in the right age. And to the second question, what age do we screen? Generally speaking, age 50 should be the time to get your first colon cancer screening test. And the screening test varies depending on your risk. And even the age at which we do the testing should also take into account your overall risk, which means your family history, taking it into account history of colon cancer, history of breast cancer, history of female genital tract cancer, or whether you carry one of the genetic makeup that puts you at risk of colorectal cancer, and what age your family member developed colorectal cancer also matters. Assuming you don't have any of the high risk factors like genetic makeup or Crohn's disease or ulcerative colitis, then you fall into the either low risk or intermediate risk category. So people who are in this category, then the general recommendation is to start screening at age 50. I can also talk about what modality of screening. There are several modalities of screening.
I was going to ask you that question.
The most common one people know is what we call fecal occult blood test, where they test your stool for blood in the doctor's office. And then there are other ways of testing your stool for hemoglobin. We call it immunoassay test. So each of them, is good, but it's not perfect. Like we said, it's a screening tool. And even if you have negative tests, it doesn't mean that you are out of the woods. And then the next level of test will be what we call combination of fecal occult blood test and immunoassay test for hemoglobin and sigmoidoscopy, where they use a camera attached to a tube to go through your backside after they prepared you, to look around to see if they can see any cancerous lesion or precancerous lesion. Precancerous lesion can be in the form of polyps or abnormal growth in the colon. And the next test that can be done is colonoscopy, where they use the same scope and camera. It's like a camera at the end of a tube, but this time around a much longer tube, to look through the whole colon, from rectal area all the way to the junction between small and large intestine, to see if they find any lesions that are worrisome or any polyps that they can remove or any growth that looks suspicious. Generally speaking, we prefer sigmoidoscopy or colonoscopy because it is both therapeutic and screening. For instance, when they go in and then they see any abnormal polyp, they remove the polyp, which means that polyp never gets the chance to grow into cancer, especially if the polyp looks weird, okay? Compared to fecal occult blood, where they just check you for blood, and sometimes people can bleed intermittently. You bleed today, you don't bleed tomorrow. Or you bleed for a few days and then the blood stops for the next few days. So if they do just the fecal occult blood test, if it is negative, it is as good as it is negative for a few days. It doesn't mean it's negative next week. So generally speaking, for people who are at the right age, which is 50 years, that's where the screening starts. We will recommend colonoscopy unless there is a contraindication, which means that there's a reason colonoscopy cannot be done for one reason or the other. Somebody is on blood thinner and we cannot stop the blood thinner and we think the risk is a little high. But overall, majority of the people are able to undergo colonoscopy. Last but not the least, most recently, there is a new test that is coming into practice for people with lower risk, where they check your stool for cancer genetic material. We call, maybe you see the commercial on television called Cologuard, where they give you the box, you go there, you take it home, you produce stool into it, you send it back to the company, and they check you for cancer genetic material. In most people who do that, if they find any cancer genetic material, they still have to do colonoscopy. So when you are taking that test, especially for those who have low risk, so the test is for those with low risk or low to intermediate risk. You have to understand that they find
you come across as saying, doctor, that the other screening protocols are not as dependable as colonoscopy. So why do you guys do them?
Yes.
Why do you do them if that's not?
So we do it. First of all, you get because remember that anything that you take, we have to weigh the risk versus benefit or risk reward. Okay, there are some people that no matter what you tell them, they will prefer not to undergo colonoscopy. In that case, then the fecal occult blood or the immunoassay, there is a protocol that you have to follow. You have to do it every year. And you have to also understand that at any point in time, if it becomes positive, then you have to do colonoscopy. So if you are somebody who is of low risk, okay, and you want to have 10 years of peace of mind, then you just do the colonoscopy, which is good for 10 years. Or sigmoidoscopy, which is good for 5 years. And if you do sigmoidoscopy, you have to combine it with annual fecal occult blood. So you see how complicated it becomes. If you do colonoscopy and you are cleared, you don't need another colonoscopy for another 10 years. So the next one will be 60, okay? And then the next one will be 70. But if you do fecal occult blood or the immunoassay with sigmoidoscopy, then you repeat sigmoidoscopy. So long as they don't find anything that will require it to be repeated, then you do it every 5 years, and you still have to do the fecal occult blood every year. So you see how complicated it has become.
Yes, truly, it's complicated.
So for most people,
yes, go ahead, sir. The reason why
for most people,
go ahead, sir.
No, go ahead.
Yes, you just said that for some reason, some people are just not comfortable with colonoscopy. Maybe one of those people uncomfortable with colonoscopy is or are the people who perhaps at some point heard the story of a Cameroonian in Maryland who went to do colonoscopy and never got up out of the procedure. I can tell you that it scared me if I had to go do it. So what would happen that somebody dies in the process of a colonoscopy procedure? What happened? What do you think happened? And shouldn't people have a right to fear?
To be honest with you, colonoscopy is one of the most common procedures done in the, in oncology by the gastroenterologist. Okay, they do thousands of colonoscopies. Okay, and so it is difficult to say exactly what happened in your family member, and I'm really sorry to hear about that incident. But by and large, it is a very safe outpatient procedure. As a matter of fact, most people are just given sedation to undergo the procedure. The procedure itself may take maximum 30 minutes to 1 hour if they don't have to do any extensive polyp removal. And most people are given some kind of sedative, like something to just make you drowsy and not completely anesthetized, to the point that you should be able to obey instruction for the procedure. So I'm pretty surprised that it resulted in the unfortunate demise of your family member. But it is easy to hear those kind of scary stories without hearing exactly what happened. I'm pretty sure that if you talk to the providers, sometimes, like I said, it is a medical procedure. There's some risk you are taking when you undergo any kind of medical procedure. And as a cancer doctor, the example I give my patient is that even drinking water is a risk you are taking. And let me give you a typical African story. There is a village in Africa where there is this man in the town who is responsible for telling people who is going to die next. Okay? And so when somebody dies, then, everybody gathers under the tree, and then he comes and says, okay, it is the turn of this household or the other household. So this continues for several years. And then, somebody dies, and then this time around the message comes that the bearer of the message is the one who is going to die next, and the person is going to die through drowning. Okay, so he decided that if it is drowning, then he is not going anywhere. They will give you the date, time, and all that. He's not going to go anywhere near water body, stream, river, whatever. He's not even a well. He's not going close. Okay, and then at the said time and date, he locked himself up in his room with his cup of water. Okay, he said, we'll see how God will kill him through drowning. Okay, and then at exactly the same time that was previously announced, he felt thirsty and decided to drink the water from his cup. And guess what? He choked and died of water from the cup. So the moral of the story is that there is no procedure that is completely without risk. But the risks are different depending on different situations. There are, and in my practice, there are patients that even we determine that, look, the risk of the local anesthesia is just too high for that patient. Okay, for that matter, we'll just do annual fecal occult blood and then, do colonoscopy if needed. So I don't want to use one case scenario, as a reason to avoid a life-saving intervention or screening test. Even though, yes, you need to ask questions when they ask you to undergo a procedure. What are my risks? What are possible complications? What exactly are you going to do? What medication am I going to be given? Those are legitimate questions.
You are watching Chat Night Africa. And the doctor today is Dr. Sunny Bukhari of Ghanaian descent. He is a specialist in oncology. Dr. Bukhari, the truth is, when one case goes bad, people are going to fear. If you had to do a procedure on somebody, a colonoscopic procedure, what are you going to screen that person for before you can engage in that procedure? What conditions are you going to make sure that the person isn't
so? Yeah.
Yes, sir. Go ahead. Yeah, go ahead.
So first of all, sorry for cutting you. First of all, you ask for indication of the procedure. Let's say if the procedure is going to be done as part of routine cancer screening, the person doesn't have risk of polyps, and you don't anticipate major intervention during the procedure, then generally that procedure is the risk is low. And then you ask the patient what medical problems they have, whether they have congestive heart failure or COPD, where their oxygen level is low to start with. That's you need to be careful when you put them under sedation, because sedation means that yes, you are awake, you can breathe yourself, but occasionally you may need to help the person to breathe. And if the person's oxygen level is low to start with, then there's some level of danger over there. And then whether they are taking any medication that will make the procedure or that will increase the risk of the procedure, risk of bleeding from the procedure. For instance, if they are on blood thinners like aspirin, Plavix, which is what we use for heart disease, or they are on Coumadin or warfarin, or new blood thinners for blood clots, definitely they need to be off those medications, depending on what you are on, between 5 to 7 days, occasionally even longer. So we check for all those. And then the next thing they will probably give you is some medication, either liquid medication to cleanse your bowel, so that when they do the procedure, they can see properly and remove any polyp if they find one. So if all those checkouts okay and the risk is determined to be low, then you are generally recommended to do the procedure. I must say that there are other ways of screening for colon cancer. Like I said, there is another actually two radiologic procedures. One of them is barium enema, where the barium is a solution that you use as an enema, and they take a picture to see if they find anything abnormal. And then another way is what we call colonography, where they give you a small camera to swallow, and then they either do a CAT scan, or the camera will just take pictures, and then they look at the pictures to see if they find anything abnormal. I must say that all this, if you do them and they find anything abnormal, you still may end up getting colonoscopy anyway. So, some people will say that, look, if you are at the right age and you just want to have something that is potentially treatment as well as screening, then colonoscopy and or sigmoidoscopy is probably the way to go.
At stage 4, for example, is there any chance the patient?
So good question. So just to summarize staging, stage 1 means that your cancer is within the colon, either in the lining of the colon inside the lining of the colon or within the walls of the colon. Stage 2 means that the cancer has crossed the wall of the colon, but it hasn't gone to a lymph node or any other adjacent organ, and it has not crossed the outer lining of the colon. Stage 3 means that your cancer has gone to the lymph node around the colon. Lymph glands are small, when you have cold sore and you feel your neck and you have a small gland that sometimes is painful, they are same thing inside your abdomen or within the what a layperson would call stomach, that carry cancer cells, or they drain the colon, so cancer cells tend to go in. And stage 4 means that the cancer has gone beyond the colon into either the liver, the lung, or lymph node that drain outside of the that drain beyond the colon. So generally speaking, we are much happier if we find colon cancer at stage 1 or stage 2 stage, or stage 1, stage 2, and stage 3. Even though we will prefer not to have stage 3, but if you have stage 3, there's still a chance of cure. If you are found at stage 4, your chance of cure goes down dramatically. Occasionally, I have seen patients who had stage 4 colon cancer who have lived beyond 5 years. By generally speaking, people with stage 4 cancer live 1 to 2 years. And usually the people who live a little longer than that are people will ask, what about Bossman? Why did he live so long? For non-oncologists, the story may look like, oh, he had stage 4, but when you read closely, he had stage 3, which was initially treated, and he was expected to survive. And unfortunately, the cancer recurred and became stage 4. So those people tend to live much longer from the time of diagnosis, because remember, they get diagnosed, they get treated with the intention to cure them, and maybe after 3-4 years, the cancer comes back.
Doctor, you are suggesting that even with the colonoscopy, the cancer could come back. Are you?
So the colonoscopy is to screen you for cancer.
Yes, sir.
Or to diagnose cancer. Once you get screened or screened and they find cancer, then the next stage will be to stage the cancer to determine how far the cancer has advanced. Depending on whether it is stage 1, stage 2, stage 3, most of the time the treatment is to take out the cancer and the lymph node around the area where the cancer is. So this can range from taking only part of the colon out or taking the whole colon out, depending on what else the surgeon sees. Okay, and then the lymph nodes with the colon. And occasionally, we do take out part of the liver or lung if we think that if we take it out, there's a good chance of cure. Now, when you get your surgery done, then you come and see the oncologist. So usually, the colonoscopies are done by the gastroenterologist, okay? And the surgery is done by the surgeon. And then after that, you come and see the oncologist. And then the oncologist will look at the CAT scan or PET scan results. They will look at the pathology results. And then they will look at your age and your risk factor, and then decide if there is a need to give chemotherapy to reduce the chances of your cancer coming back. So those are the way, the treatment decision-making tree. That's how it goes. So first of all, let's say you have somebody who had bloody stool, and then they come and see me, I'm going to send them to a gastroenterologist. The gastroenterologist will do a colonoscopy and do a biopsy. If it is indeed a colon cancer, the gastroenterologist then refer them to a general surgeon or colorectal surgeon who will do scans and then, pre-op, what we call pre-op evaluation. Once they determine that you are fit for surgery and indeed your cancer is localized, because occasionally we have people who get diagnosed and right at diagnosis their cancer is already stage 4, which means if surgery is not an option, then those patients get sent to me. But if it is stage 1, 2, or 3, then you go to the surgeon. The surgeon also makes the assessment and see if it is operable, which means can he operate on you. And if the cancer itself is operable, or if he can operate on you, then you yourself must be fit for surgery. So those two can be different. There are some patients whose cancers can be operated on, but they themselves cannot survive any kind of major surgery. Then, in that case, even though it's stage 1, 2, or 3, unfortunately, they send the patient to the oncologist to treat as if this is stage 4. So once the surgeon determines that the cancer is operable and the patient is operable, they go ahead to operate. Okay, and then when they operate, now they get the result and they send you to the oncologist or medical oncologist who will look at everything and they will look at the patient and determine if surgery alone is enough. If they determine that surgery alone is enough, then we just put you on what we call routine monitoring or surveillance, where you come every 3 to 6 months, for the first few years, and then we make it every 6 months for another few years. And then when you are 5 years, we say, well, generally, if you survive any cancer for 5 years, you are considered cancer-free. But it doesn't mean that the cancer can never come back. It's just based on our definition, what we define as being cancer-free.
Doctor, we are talking...
But occasionally, when you see us...
Yeah, Doctor, we're talking about treatment. A very important question I have here for you, and it's been sent to me by text. Someone watching this broadcast, she's referring to chemotherapy. Doctor, chemotherapy a necessary evil? Is chemotherapy a necessary evil?
So like I said,
and part B of the question is, why is it that... Yes, sir. And you're going to explain why it is necessary evil. Part B of the question is, why is it that people who have cancers tend to look so pale? They're like drained out. They just lose energy. They're like walking skeletons. What happens?
So the cancer itself can cause people to lose weight. We call cancer-associated weight loss. And this can be the result of, number one, what we call disease burden, how much cancer you have. Because remember, cancer is fast-growing cell, okay? And remember, when we are growing up, you actually grow the fastest in the first 2 years, after which your growth rate reduces, believe it or not. Same way, cancer cells growing in your body uses a lot of energy from you, okay? And the energy can be in a form of glucose or in a form of carbohydrate or in a form of already stored fat or glycogen from your body. So if the cancer doesn't have enough energy from the food you eat, the next will be to use energy that you have stored, okay? And so once it starts using the energy that you have stored, either in the form of fat or carbohydrate, then you lose weight from just losing the glycogen in the muscle or the fat from whatever fat stores you have. Occasionally, cancer also produces certain chemicals that causes wasting. So we call it wasting syndrome chemicals. So even without the cancer growing, the wasting syndrome chemicals can cause you to lose weight because it increases your body metabolism to the point, for instance, if you take people with leukemia and lymphoma, they have nice sweat, weight loss, their appetite is down. It's because of those wasting syndrome chemicals we call interferons and interleukins, which just cause your body to lose weight through loss of appetite or just increase body catabolism or breakdown of fat and glycogen. Coming to the chemotherapy, and then occasionally the chemotherapy itself will result in nausea, vomiting, poor appetite, and hence poor weight gain. So coming to chemotherapy, when somebody comes to us, first of all, we have to determine if you have cancer or not. And then we have to determine the stage of the cancer. And then we have to determine what we call the goals of treatment. Okay, because there are people who see us and we determine that the goals of treatment is curative, which means that you are treating them to cure them of the cancer. And this can be by treating the cancer itself, or the person may not have cancer, but you want to give them chemo to reduce the chances that the cancer is coming back. And remember, even if we do scans and we don't see cancer, there may be small cells floating around, and we give chemo to kill those cells and reduce the chances that the cancer is coming back. So if let's say if somebody has stage 1 and 2 colon cancer, generally speaking, they will not need any additional treatment so long as the surgery is good. The surgeon got everything, and then you get all clear from the CAT scans that you do after surgery. Overall, patients with stage 3 cancers, stage 3 colon cancer will end up getting some form of chemotherapy. What you get is going to be determined by the patient characteristic, which is how the patient looks, or the cancer characteristics, how the cancer is, or combination of patient and cancer characteristics. So I've seen patients where we make determination that, their risk of cancer coming back is low, so we don't want to beat them up too much. And then I have patients, we say, look, we want to give you the best chance of getting this. And you are very young, you are healthy. We want to make sure that we do everything we can to reduce your chances of cancer coming back. Again, it doesn't mean, remember, I didn't say to cure your cancer, I said to reduce the chances of cancer coming back. What it means is, let's say, a lot of the cancers, if you don't do anything, maybe the cancer has 5 out of 10 chance of coming back. So for every 10 patients who have your exact cancer, your exact age, your exact clinical condition, 5 of them will come back if nothing is done. And so then we say that if we give you chemotherapy, 10 patients, exact same characteristics, we are able to reduce the number of patients in whom the cancer comes back to 2. So remember, it's not all of them. We only reduce it to 2 people. The tricky part is, and I always tell patients, I wish I have the magic bullet to tell you that for you, it's not coming back, for next one, it's not coming. I will be out of oncology. I'll just sit in my office and be a soothsayer, okay? And then charge you money. You come and see me and I tell you, you know what, forget it. You're going to be bad. And then the next person can say, oh, don't worry, don't forget the doctors. You're going to be just fine.
You are watching Chat Night Africa. I have watched people or some medical doctors online suggesting that cancer survives in your body on some food nutrients, for example, carbohydrates. Perhaps you've watched videos like that. I want to ask you about the veracity of what they say. Is it true that if you had cancer, even stage 4, you could starve it off or out of your body by not feeding or eating the things that the cancers feed on. I want you to react on this. React to this.
Unfortunately, that statement is not accurate. Okay, because remember I said that the wasting syndrome of cancer can come directly from the cancer itself, where the cancer uses any form of nutrient in your body, and it doesn't matter whether you eat or you don't eat. As a matter of fact, we encourage cancer patients to eat well. I tell my patient, look, food is medicine when it comes to cancer care, because I want you to be healthy enough so that when I give you chemo or whatever treatment, even if you're going to get sick, you will not be too weak. As a matter of fact, if you are too weak, nobody gives you treatment because you will just get weaker and die. So the reason why people always speculate that cancer feeds on sugar, okay? But the sugar, whether you eat sugar or not, or you eat food or not, you eat carbohydrates or not, the cancer cells are going to get their nutrients by producing chemicals that will cause your body to break down the already stored chemicals like fat and glycogen, which is the storage form of sugar, okay? So, the example I give all my patients is that it's like if you have 4 boys, okay? You have a family of 4 boys, and 2 of them are big boys, and 2 are, small. They are relatively smaller. Just imagine giving them insufficient food, and you ask them, okay, you eat the food together. The 4 boys are going to eat as much as they want to eat, and the 2 boys are going to starve. So what do? Either you give them enough food such that let the 4 boys eat whatever they can. They will just be satisfied and then be looking at the rest of the food. And then the weak ones will have their share. Okay, so the same way, in whether you eat sugar or not, the cancer is going to take its sugar from your body. And that's why people with cancer lose weight. It's because, number 1, your appetite is down. Number 2, the cancers are producing wasting chemical or chemical that causes body wasting. Okay? Your body will break down its own storage form of chemical like carbohydrates and glycogen in order to get them to survive. Cancer feeds on sugar is a myth.
I'm glad that you clarified that, but there's some logic to explain that myth, because if divine feeds on something, like I come from a village in Cameroon called Bali, we eat a lot of corn fufu and smoked fish and vegetables. So the assumption is that if that's what I like to eat, and then you take away that, then I should die. I think that's where the reasoning is.
Yes, but the thing is that, remember that cancer works it works directly and indirectly. If you eat enough energy-giving food, it takes the energy-giving food from you. If you don't eat, it will cause your body to break down your already stored. It's pretty much like, the reason why we continue to work, even if you are rich, is that if you don't work, then you have to use whatever you have in the bank, right? So what happens? As time goes on, if you don't continue to work to replenish it, you know what's going to happen? You're going to be poor, and then you have nowhere to fall on, right? So the same analogy works for cancer care.
And I'd like to inform our viewers that you can dial. This program is not going to go beyond 90 minutes. You can pick up your phone. If you have a phone, you have a specialist. I tell you, people like Dr. Sunny Bukhari are expensive to meet, to consult. It's not cheap. And listen, we've opened the microphones now. The phone lines are open. You can talk to this guy right now. If you have a phone, you have a doctor, and not any kind of doctor, a specialist in cancer. I'd like to also inform you watching that our correspondent for African Affairs, Jerry Johnny, will be live from Nigeria today with this week's news roundup across Africa. So stay tuned for that report. Doctor, there are chances are high that, or this is possibility that people are breaking into this broadcast midway. I'd like you to repeat the area which you said our lifestyles could be the reason why we develop colon cancer. Is very important. In other words, what we do could lead to colon cancer. It's a whole different story if you inherited this thing from your parents or from relatives, so to speak. But if you're going to take your hands into your mouth...
So, when I was talking about some of the causes...
Then what are those things that we do that would lead us down the path of developing colon cancer? I'd like you to repeat that, sir.
Yeah, so I mentioned at the beginning that the causes of colon cancer can be divided into 4 main categories. Okay, the first category is what we call congenital. Congenital means you are born with certain characteristics that puts you at risk of cancer. And when you have congenital, means that the characteristic may be given to you by your parents, which means hereditary. And there are several hereditary cancer syndromes that increases your risk of colon cancer. One of them, the most common one that people hear about, is hereditary polyp syndrome, where some people are predisposed to developing polyps, and occasionally one of the polyps will become cancerous. And then there's hereditary non-polyp syndrome called Lynch syndrome, where you carry set of genes or genetic information from your parent that will put you at risk of cancer. And then there are some people who don't carry exactly the colon cancer gene that puts them at risk, but they carry other genes or other cancer carrying genes, like the breast cancer gene, the female genital tract cancer gene, which also put them at risk of colon cancer. And then there is also part of the congenital or born with it is that during fertilization and cell division, when you are in your mother's womb, you develop certain changes in your cells that were not passed on by your parents to you, but put you at risk of developing colon cancer. Then the next, we go to acquired factors. Some of the acquired factors include westernization of our diet. And when I say westernization diet, typical indigenous diets are mainly complex carbohydrates, a lot of vegetables, complex starch diets, like the ebas and the bankus and the fufus and the omutuos with moi moi, and then most of our vegetable soups, cassava leaves, and those put you at lower risk. But when we westernize our diet, where we start taking refined sugar, pastries, biscuits, and all those put you at risk of colon cancer. And then there are other disease conditions like ulcerative colitis and Crohn's disease. We call both of them inflammatory bowel disease. They put you at risk. And then last but not the least are certain general predisposing factors like obesity, like being on the bigger side of normal, diabetes, alcohol use of red meat. And when I say red meat, I mean a lot of it. And then tobacco use may also put you at risk of colon cancer. And then I spoke about protective risk factors or protective factors, high fiber diet, complex carbohydrate diet, folic acid, vitamin B6, calcium, and non-steroidal anti-inflammatory drug like aspirin may also reduce your risk.
Some people thought,
and the last but not the least,
citrus fruits, lemon, lime, and all those things.
Yes, fruit and vegetable are relatively high complex carbohydrates. most of the fruits and vegetables are complex carbohydrates with a lot of roughages. When we say roughage, we mean, especially fruits that you eat the whole fruit. Okay, like let's say pawpaw, you're going to eat the whole pawpaw. So it's made up of the sugary component and then the roughage component. Banana, same. You are eating the whole banana. It's not just the sugar in the banana. On the other hand, some people, instead of eating the fruit, they juice it. So when you juice, you are taking the sugar component and you are throwing the roughages away. So the new juicing methods that people use, where you juice the whole thing instead of, squeezing the juice out of it.
That's very important.
It's probably the better method.
On the contrary, people thought that when you juice it and just took the liquids of it, you're getting the better part. Oh my goodness.
No, actually,
boy, ignorance. You see,
let's say if you take.
This is why Chat Night Africa will believe that when we bring people, powerhouses like Dr. Sunny Bukhari, they come to weaponize you. Because while ignorance could be a bliss, knowledge is power, especially knowledge that you act on. Yeah. Very, very important. It's good to listen to these things, but after listening to this, if you say, hey, look, you know what, Divine, I continue to eat my meat every day, let me continue to juice my stuff, well, we would have played our part. It's not up to you to act. Now, my last question for the day, for this week, Dr. Sunny Bukhari, is what are other complications of colon cancer? And I ask this question as the last question on purpose. People generally do not act if they do not know what complications certain things expose them to. Diabetes, the same thing. High blood pressure, the same thing. People don't act until they know what problems it would bring them. So what are other complications of colon cancer, sir? And that would be my final question.
So, so colon cancer complications, the most feared complication is death, and especially for patients or people, unfortunately, who have stage 4 colon cancer. So our goal is to reduce death from colon cancer. And how do we reduce death? Is to make sure that we diagnose it early, which means that even if you have symptoms, don't wait or procrastinate until things get really bad. Abdominal pain, change in bowel habit, either conspirator or combination. Bloody stool needs to be checked. Dark stool needs to be checked. Weight loss. And for those who do not have symptoms, if you are at age 50. So for those, and let me make this very clear. The age 50 is for those who are deemed not to have any other risk factor, okay, and any other symptom. Then you should have screening tests, and the screening tests can range from occult blood test, where they just take your stool and check for blood, sigmoidoscopy, where they use a camera with the scope to look through your backside to check for polyps and early stage colon cancer, or colonoscopy. And then occasionally there are cancer genetic tests that they could do, and then they can also do CAT scan. So we will recommend strongly for us to do whatever it takes to get diagnosed early. If you don't get diagnosed early, the chances of survival goes down dramatically. I said that for stage 1 and 2, your chances of survival 90%. For stage 3 and stage 3 is probably around 60-70%. Stage 4, unfortunately, very few people survive it. When you develop colon cancer, you can have complications that include extension of the colon cancer to the lung, where you have bloody sputum, extension of the colon cancer to the liver, and occasionally to the lymph node and bone where you have cancer-type bone pain. Last but not the least, if the cancer goes unchecked, it can obstruct your intestine. And when I mean intestine, either the small or large intestine or combination of them. And then you have what is called cancer-associated abdominal pain. Occasionally, it may require colostomy as a temporary measure or permanent measure. And finally, death. And why we are talking about this is to try and decrease cancer-associated death.
This is Chat Night Africa. And before you go, what's your last word, Dr. Sunny Bukhari?
My last word is to encourage people to seek early screening. You know, that's very important. And when I say early screening, I mean go to your doctor, let your doctor evaluate your personal history, your family history, your social history, and determine if you belong to average risk or high risk. And whether average risk or high risk, then your doctor determine when exactly the colonoscopy is appropriate. And like I said, for instance, if you have somebody whose father died of colon cancer at age 43, and the father was carrying colon cancer associated genetic makeup, and if you are unfortunate to inherit that genetic makeup from your father, waiting until age 50 to do colonoscopy is not the right thing. You have to see the doctor, let the doctor make a determination when is it that colonoscopy should be done. And I have personally referred patients. I will give you an example. I had a patient that I was seeing for thalassemia, and until the twin sister died, I didn't know that this patient had twin sister. Okay, it's bad on my part, but I wasn't really seeing. I know he had a sister, but I didn't know that I was twin sister. So and then he didn't show up for his appointment one time, and then he showed up the next time. I'm like, this is the first time you miss your appointment. What happened? He said, oh, my sister died. I'm like, your direct sister? He's like, no, my twin sister. And then what did he die of? He was being treated somewhere else for colon cancer. Okay. And this guy is 42. So I asked whether the sister had a genetic test. He said, yes, but I don't have the result. I'm like, we need to get the result ASAP. So guess what? This guy carries the same genetic test or genetic makeup as the twin sister, right? Twins. So I sent him right away for colonoscopy because he's already late, actually. So, and then they found few polyps that were removed. I'm not saying the colonoscopy saved him, but it probably did. If we didn't know that, we would have waited till he turns 50, which is 7 years down the line. Okay,
Doc.
Who knows what would have happened in between? That's why I stress the importance of seeing your doctor and making sure that they appropriately put you in the right risk category.
Dr. Sunny Bukhari. Doctor, I would have brought some barbecue to share with you on the show, and maybe some liquor, some beer. But since you have warned against it, the only thing I could give you as a friend, a dear friend of Chat Night Africa, is a traditional piece from where I was born in Cameroon called Bali. Well, you may not be able to dance to the music because you probably will be listening to it for the first time, but it's definitely something that you will like. I hope you like that.
So yeah, somebody asked a quick question. So
All right.
I think it's Ade Rosita.
Yeah, Rosetta Ade from Delaware.
Yes, and I think she was referring to either somebody had colon cancer, and do we recommend for her to start screening at age 35? So usually, once you have a family member, close relative, first degree relative, let's say sister, brother, father, mother, who had colon cancer, first of all, the person must be checked for colon cancer associated genetic changes. It can be done on the tissue, even if she's dead, or if she's alive, it can be done with a blood test. Once that is done, if they carry one of the colon cancer associated genetic change, then you yourself need to see a genetic specialist for them to see if you carry the same genetic change as your family member, the close relative, sister, brother, mother, or father. If they determine that you carry the same genetic makeup, then the recommendation will be to start screening. Remember, because it's a screening, we want to catch it earlier than when your family member was diagnosed. So generally 10 years before the age they were diagnosed. So we catch it early and deal with it. So occasionally they may, depending on what you had, they may recommend to have a complete colectomy, where the whole of your colon is know that your risk of cancer is pretty high.
Okay, we've got to go now.
So that's my answer to her question.
Thank you, sir. Thank you so much. As you see, Dr. Sunny Bukhari has been connecting with us from outside his gardens in California. And it's getting dark there now. And so we've got to let him go. Thank you, Doc, for coming.
Yes.
Thank you, Doc, for coming. And please, if you still have questions, post them. Dr. Sunny will be checking in the green room and answering your questions. If you want to connect with him, of course, that's one of the things we do at Chat Night Africa, and we do well. We connect people, even in Africa, to doctors in the United States. Please feel free, contact me if there are questions when you talk to Dr. Sunny. Thank God for WhatsApp. Thank you, sir, and give my regards to your beautiful family, sir.
Thank you very much.
Thank you, sir. Bye-bye.
Thank you.
Ladies and gentlemen, we are going to wrap up this broadcast with a report. I told you that we have correspondents around Africa. Our chief Africa correspondent is Jerry Johnny, who now presents Africa This Week in the News. Stay tuned for that report.
Welcome to Chat Night African Live News. We start off from Nigeria this week. The Ebonyi State Police Command has declared a lawyer wanted for conspiracy and attempted murder. The State Commissioner of Police, CP Philip Marco, disclosed this to pressmen while parading 23 suspects arrested for different crimes at the command headquarters in Abakaliki, the state capital. The police boss stated that one Barrister Kennedy Abai, who is now at large, hired heavily men numbering about 30 from Anahiba, the Inisia Kwanto local government area of Abia State, to storm the Heme village in Isiago Autonomous Community. Destroy houses and properties worth millions of naira. Stated that preliminary investigation revealed that there were an outstanding 8-long land dispute between the Obasi and the Heme villages, which the case in court judgment was given in favor of Ndi Obasi, which prompted Ndi Heme to appeal the judgment. Quickly, we move to Ghana, where the presidential candidate of the National Democratic Congress, NDC, John Dramani Mahama, says this year's general election will be based on the trust that the electorate have for the leaders of the two main parties. Addressing members and supporters of NDC at Jeripa on Friday as part of his 4-day campaign tour of the Upper West region, Mr. Mahama said the NPP, on the watch of Nana Akufo-Addo in the year 2016, succeeded in waging succeeded in waging a campaign of false promises to sway voters. But the December general elections, it said, is about comparing the record of the two parties. Mr. Mahama also justified the selection of Professor Jane Nana Opoku Akiaman as his running mate, adding that she is highly qualified and has the needed credentials to serve the people of Ghana. Meanwhile, the president of the country and the presidential candidate for New Patriotic Party (NPP) in the June 2020 general election, Nana Akufo-Addo, has said that he is not a tribalist as some persons are painting him to be. President Akufo-Addo said although he has his weaknesses, tribalism has never been part of his life, and therefore asks that those who promote ethnic sentiment and division should be rejected. Moving on to Cameroon now. Government leaders in Cameroon have been accused of being more interested in fighting the opposition than COVID-19. Despite accusation of putting the population in harm's way, the government has reopened airports and schools. Cameroon has one of Africa's highest infection rates, with more than 200 people reported dead at 6,000 cases. Now to Uganda. Uganda's COVID-19 task force has proposed the reopening of a Tembe airport, borders, places of worship, and universities for final year medical students. According to the proposal sent to President Museveni on Monday, the task force maintained the closure of schools, bars, and public gyms, among others. The task force proposed that Ministries of Education and Health will study the possibility of reopening the schools. On prayer centers, the task force said worship places should reopen, but the number of worshippers should not exceed 70. In the same proposal, the team dropped the consideration for a lockdown in Kampala City. Sources who attended the meeting on Monday said the proposals were sent to President Museveni for final consideration and approval. In Tanzania, RAN-A is set to reap big in Tanzania as it fills the vacuum left by Kenya's airlines, which were banned from flying into that country. The airline, in a post of its website, announced that it will be operating 3 flights to Dar es Salaam and Kilimanjaro via Nairobi, Kenya. The news is a relief to many people who had to travel to Rwanda or Ethiopia to get to Tanzania. The other options was using the road all the way to Tanzania, a long and tiresome journey. Tanzanian aviation authorities banned Kenya Airways, Air Kenya Express, Fly 540, and Savalink Aviation from flying to Dar, Zanzibar, and Kilimanjaro. This was in retaliation to Kenya subjecting passengers from Tanzania to a mandatory 14-day COVID-19 quarantine. Now moving on to Mali, President of the National Committee for the Salvation of the People, CNSP, Assimi Goïta, prepares for a meeting between Malian military leaders and an ECOWAS delegation headed by former Nigerian President Goodluck Jonathan on August 22nd, 2020, in an aim to restore order after the military coup in Bamako. Mali's military junta began talks with the opposition group on Saturday on its promise to hand power back to civilians after mounting pressure from neighboring countries in the week since it overthrew the nation's leader. Meanwhile, Mali's ex-president Ibrahim Boubacar Keïta, who was ousted in a coup last month, has left the country. Keïta, who is 75 years old, fled to the United Arab Emirates on Saturday for medical treatment after suffering a minor stroke, military officials said. And that is Chat Night Africa Live News. Thank you so much for being a part of it. My name is Jerry Johnny, and I'm reporting live from Nigeria.
Thank you, Jerry Johnny, our Chief African Correspondent for Chat Night Africa. This will be a regular menu each time we are on the air. Ladies and gentlemen, that has been Chat Night Africa Live from Washington, D.C. metropolitan area. Chat Night Africa Live. We have production advisor Dr. B Tatsong Fomundam. Chat Night Africa Live, the power of Chat Night Africa. Production supervisor, transmission director, Mumbalingwa. Our social media platforms manager and video editor, Sir Roger Fool in Lagos, Nigeria. Studio manager, Beatrice Fomunen. Production assistants, Emmanuel Gwayinji, Daniel Eno. We have John Tanto and Uncle Lord Benson at Frontier Street, Bamenda. Chat Night Africa is compiled and presented by Divine Chamukong. Merci à tout le monde. I will see you again soon and very soon for yet another John T broadcast. Thank you, Dr. Sunny Bukhari in Fresno, California, for answering my questions at Chat Night Africa. You have a wonderful week until we meet again. Bye-bye now.
We're gonna get down.